So good morning, and I'd like to thank the organizers for giving us an opportunity to present a summary of our data that will be presented on Monday morning by Nirali Shah. And what I'll be presenting are results of a phase 1 clinical trial using CD22 targeted chimeric antigen receptor T cells in children and young adults with refractory ALL. I think most people in the room are familiar with the success with the CD19 chimeric antigen receptor expressing T cells in BALL with complete remission rates approaching 80 to 90% in treated patients now in phase 2 clinical trials. We're learning now that one of the limitations of this approach is loss of CD19 expression occurring in potentially a substantial number of patients, although that has not been systematically analyzed. CD22 is a well-defined alternative target in BALL, and there are existing monoclonal antibody toxin conjugates that have shown efficacy in BALL. So based on this, a number of years ago within the NCI, we developed a CD22 targeted chimeric antigen receptor. I don't have time to talk about that in detail, but suffice it to say that although there are a number of binders that seem active in the CD19 CAR space, it was very difficult to come up with an active antibody-based binding domain that was functional as a chimeric antigen receptor, and so we cycled through a lot of binders that were inactive before we finally arrived at M971, which was active as a chimeric antigen receptor. So we took this into the clinic and opened a phase 1 dose escalation trial using these anti-CD22 CAR T cells, fairly standard relapsed refractory ALL population, obviously expression of CD22 required. Age is shown there. We did allow CNS disease, but CNS3 was exclusionary. All patients received the same preparative regimen shown there. The dose escalation is shown below. I'll point out that dose level 2, 1 times 10 to the 6th, is the dose that has been used in most of the CD19 CAR trials. We started a half a log lower than that as part of the safety in the trial. These are the characteristics of the patients treated thus far in the dose escalation and the initial experience in the expansion cohort. I'll point out a couple of things. All of these patients had received a prior allogeneic transplant. 11 of these patients had received CD19 CAR, and 9 of these patients were CD19 negative or had reduced expression of CD19 on the surface of their ALL. Most of these patients were high burden disease patients, 12 of them greater than or equal to an M2 Maryland enrollment. We had 3 patients with extramedullary disease. So this is the experience from the standpoint of toxicity. We expanded dose level 1 due to a grade 3 diarrhea that was self-limiting. We then escalated to 1 times 10 to the 6th, treated 3 patients with no DLT. As per protocol design, we then escalated to 3 times 10 to the 6th. We had 1 patient who developed grade 4 hypoxia necessitating early initiation of steroids with rapid reversal. Although we could have continued with that dose level based on the response in dose level 2 and the 1 DLT, we made a decision to go back down to 1 times 10 to the 6th, and we've treated additional patients at that dose level. We have had 1 grade 5 event due to sepsis that occurred after resolution of CRS. We've seen an 80% complete remission rate at dose level 2 or greater, with a maximum grade of cytokine release syndrome of 2. This is not based on CTC grading. This is based on a publication from Blood that includes all of the clinical aspects of cytokine release syndrome. This is the waterfall plot for the patients treated thus far. Dose level 2 and 3 are in green and blue. And so, again, a very high remission induction rate once we achieve the biologically active dose. The hash bars represent the development of cytokine release syndrome. We have seen sustained remission. We have 3 ongoing remissions, 1 patient at greater than a year, another patient at 6 months, and another patient at 3 months. This obviously means that we have seen relapses, and Of interest, these relapses have been associated, at least in the 4 patients treated at the biologically active dose, with changes in expression of CD22. It appears to be different than with CD19, where CD19 is lost completely. In these patients, we saw largely a decrease in site density that we think drops the CD22 expression below the threshold for CAR activity. We have seen one patient with CD19 negative who completely lost CD22 expression on her blasts. So in conclusion, I think this is the first successful salvage CAR therapy for CD19 negative BALL. The preliminary experience certainly suggests that the potency is at least comparable to the phase 1 experience with CD19 at the same dose level. There was a suggestion that response tended to correlate with dose level. We did see CRS with a maximum grade of 2. This evening there'll be a poster presentation by Haneen Shalabi on the experience with the neurotoxicity. When we wrote this trial, we included comprehensive evaluation for neurotoxicity. We did not see any severe or irreversible neurotoxicity thus far. We've seen that relapse is associated with changes in CD22 expression, and at least our bias is that this may not be best used as a salvage therapy, but we're beginning to think about how this could be potentially included with CD19 in the upfront CAR treatment. The acknowledgement shown here, this trial was fully developed within the NCI, and the IND sponsor is the Center for Cancer Research. We did have lentiviral vector production produced by Lentigen as part of a CRADA. After trial initiation, Juno licensed the CD22 CAR construct. We have an ongoing CRADA that supports data transfer and correlative assays, but it is still an NCI-sponsored trial.